Wonderful weather out there, and glad that all of you came along to enjoy both the cherry blossoms, the wonderful weather, and a great evening. And I'm really happy to say we've got another sellout this evening, so it's wonderful. Couple of quick ones. Please turn off your cell phones or your iPhones or your Blackberries, especially just a quick request to the panelists. Our cell phones tend to interfere with their microphone, so you'll get feedback if those are on or things like that. So if you don't mind. Before we start, I'd like to briefly thank all of our sponsors and those supporters who help make the VEF affordable for all of us to join and enjoy. We're always looking for supporters and sponsors, so if you would like to get involved, please feel free to see myself or Chris, our executive director, up at the front desk. Drop off your card and we'd be happy to follow up with you. One of our longtime sponsors this evening is the UBC University Industry Liaison Office. With 1,000 industry-partnered research projects annually and more than 250 active licenses, over 150 spin-off companies, UBC researchers interact extensively with local, national, global industry partners and entrepreneurs. UBC's Industry Liaison Office facilitates this interaction and is focused on building ongoing partnerships that are appropriate to changing the more open models of innovation. UBC is finding new ways to engage industry with expanding academic research through initiatives such as Campus as a Living Lab. It is expanding the ways in which it can share knowledge and research discoveries through simplified licensing, mobile apps, and other non-proprietary routes, and increasing its support of entrepreneurship through programs such as Entrepreneurship at UBC, which includes ULIO offering free startup services to new ventures founded by UBC students and recent alumni. If I can ask Jamie Hall and Jennifer Lynette to stand up and be recognized, and thank you very much for joining us. And there we go, way up top in the back. Thank you. Also, another one of our sponsors, Vantage Capital. Vantage Capital is a new venture capital fund focused on investments in interactive entertainment and digital media businesses. They make investments where their unique combination of operating leadership and management can add value. Subject matter expertise and relationships with technology, creative, and management talent can help generate outsized returns for entrepreneur. If I can ask Amy Ray and Mo Kermani and Brian Martin to stand and be recognized. Up at the top of it again. Thank you very much. So, just to speed things along, I'd like to welcome to our stage Michael Badu, the founder and CEO of Sanatron, which is sponsoring our lightning pitch segment tonight. And Michael, if I can hand the microphone over to you.
Thanks very much, Tim. All right, thank you very much, Tim. And I'm the CEO and founder of Sanatron. If we can get going with our presentation. Are we ready? I can just click. Okay. So here we go. Wrong way? Forward. There you go. So we have 600 seconds to do about 6 pitches. This is who we are, Sanatron. We'll talk about some bad ideas. Picnic pants, fut to be gone, ostrich nap pillow. What a great idea. Hey, what a bad idea. And then a great idea. This is Scanadu. If you don't know about this, this is unbelievable. It's the tricorder of digital health industry right now. It's unbelievable. It's happening in San Diego right now. It's a NASA project. This will self-diagnose people. Amazing stuff. And then when I looked at all that stuff, bad ideas, worse ideas, I thought we should have a technology accelerator in Vancouver. It's a not-for-profit, started in 2012. We help entrepreneurs to build solutions focused on real problems. And we have a bunch of things that we offer, like services, programs, financing, customers, access to customers, and a bunch of events. We have a number of local and global events as well. And I'm going to finish with an invitation to you all at Interface 2014, September 29 and 30th. We're also going to be looking for sponsors, speakers, and companies. And here we go. This is the last part of my pitch. So.
was the Interface 2013 Digital Health International Summit. One participant called it the best Canadian conference she's ever attended. No wonder. Interface 2013 attracted health professionals, design experts, digital and mobile developers and entrepreneurs, venture capitalists and other professionals from 7 Pacific Rim countries. They represented 130 companies, all active or interested in disrupting conventional healthcare models with more efficient and effective digital health systems. 40-plus speakers and panelists with international credentials delivered inspirational keynotes, critical insights, and 18 entrepreneurs pitched the latest and greatest digital health apps and technologies. And everyone enjoyed numerous opportunities to connect, make friends, and do business with international digital health colleagues. Now you know why Interface 2013 won overwhelming approval from all who attended. So what could possibly top all that? Interface Digital Health International Summit 2014, coming next fall. Prepare to be surprised once more.
This fall, September 29th and 30th. So I hope you all enjoyed the show. Thanks very much. So with that, before we go into the pitches, I'd like to thank the VEF board for inviting me and Sanatron to be here with you tonight. I'm very pleased to introduce the first speaker. We have Duane Nicol, actually, from Cientis Technologies. So up we go.
Check. Hello? Ready with the timer? Okay. Hi, I'm Duane Nicol from Cientis. I'm here to tell you about the company and the missing consumer reports we are for the medical industry. Founded 7 years ago, Cientis set out to work as the U.S. and Canadian government reach branch for assessing readiness for electronic health practitioners to adopt various technologies. Through the process, we have become the primary reporting system that allows over 25 associated partners like the AMA, American College of Physicians, and others to understand if their investments into the healthcare are providing a very good ROI or not. Cientis has a community of over 750,000 medical professionals through our network, representing about 75% of all American doctors. The value provided is immense, and doctors tend to trust other doctors who have similar-sized practices. Throughout innovation and ingenuity, we have completed surveys that have produced a plethora of data, allowing those who direct over $26 billion of public funds to make sure their investments are solid and work. We are growing. We have turned and moved into Singapore, and we're currently negotiating with the Chinese government. We're seeking a mezzanine-level investment by those who understand the health industry. We have a unique business proposition that can fend off newcomers, a solid partnership with the right levels of government, and a solid value proposition. We have a board that understands and includes seasoned IT, C-level personnel, doctors as founders, and support from the entire industry. Cientis is a hot investment. It is an opportunity for someone to come on board and grow with our global reach. We're adding value to the health industry as a total, and we hope you come on board and join us. Thank you.
All right, so the next pitch is Dr. Maryam Sadeghi of MetaOptima.
Hi, MetaOptima is a software company focused on unlocking the potential of today's smartphones for healthcare improvements. Our first product, Molescope, is a hardware and software solution that will revolutionize early diagnosis of skin cancer. During my PhD at BC Cancer Agency, I was shocked at how archaic the technology was for skin cancer screening. Skin cancer is the most common cancer, with more than 150 million patients worldwide. Interestingly, 70% of skin cancers are found by patients themselves or their family members who have never had any access to any imaging device to look at their moles closely and find cancer early. By using our technology, our convenient technology, we think the potential of finding a skin cancer early will be improved only by leveraging the power of the technology that people use every day. Based on our 4 years of award-winning research, Molescope is designed to help people self-monitor moles using our mini microscopy imaging device and our software for remote diagnosis. We are looking to raise $500,000 to actually launch our product in fall 2014, and we are looking actually for value-added investors to help us through this very exciting journey. Thank you so much.
All right, so the next pitch is Angela Robert, the CEO of Conquer Mobile. So.
There we go. Hello, everyone. My name is Angela Robert, and I'm the CEO of Conquer Mobile. What we're doing is developing a platform using virtual reality and medical simulation to teach perioperative nurses what instruments to hand to a surgeon during a particular surgery. What we're trying to do is be a complement to existing methods. So job shadowing, as an example, we want to cut down the time of job shadowing by teaching them instrumentation and saving the hospitals money. We've currently got a demo on iPad as well as Oculus Rift, and we're using them for market research as well as early sales and medical research. These are our customer segments in North America. We're talking to people in all of those different segments. And these are the key users. So these users do the 100 million plus surgeries every year in North America. And what we're trying to do is teach the people delivering that great care. This is some of the traction that we've received already. Some notables include AORN and the Community Health Systems Network. We went to the AORN conference in Chicago a couple weeks back, and now we have 120 perioperative nurses that absolutely love us and want to be advisors. What we're looking to do is raise $2 million, basically to execute our roadmap and strategy going forward. And the team, we've got a really great team. We've got a medical board of advisors, and they're there to support us and help us techies deliver really great content. Thanks.
All right, thank you, Angela. The next pitch is Dr. Daniel Schwartz of QxMD.
Thanks very much for having me today. So QxMD is tackling the problem that physicians want to do a great job but are overloaded with information, and the healthcare system is now expecting doctors not to process a volume of patients but provide high-quality care. Our solution that we've built is a set of applications called Read and Calculate, which ensure that doctors always know the cutting-edge research, which will enhance their practice and can apply it accurately at the point of care. It's an exciting market to be in. 550,000 U.S. physicians are using mobile devices on a daily basis. Promoting content to doctors, which is our business model, is a large one, $24 billion in spending, of which 1.2 is digital and growing. Our adoption has been very exciting. Active users in healthcare, 884,000, 83,000 of the U.S. physicians are ours. And now we're partnering with clients and academic medical centers. We've generated revenue last year. We're cash flow positive and continuing to grow. Our revenue model is based around native advertising, in that we embed content that our sponsors are interested in having promoted to our physicians and our healthcare audience. We use promoted research just like Twitter and Facebook do, except we promote research instead of tweets and Facebook stories. And Calculate allows us to put digital interactive tools in the hands of doctors. We're looking for investment, and we'd like you to be part of that if that's of interest. We're growing rapidly, and we're going to be interested in speaking to you at the end of the event if you have a few moments. Thanks very much.
Thank you, Daniel. And the last of the 5 pitches is Nick MacKinnon from eTreat Medical Diagnostics.
Hi there, Nick from eTreat Medical Diagnostics. Our mobile apps and cloud software turn cell phones into true medical devices. Now, mobile health revenue is expected to reach $23 billion globally in 2013. About 70% of this is going to be directed to chronic disease management. Now, digital health and mobile apps are rapidly improving quality and access to care, especially in emerging healthcare markets. Most health apps are either data logging for fitness or pain management, SMS text message reminders, or informational, the equivalent of a book or a pamphlet. Apps with true medical device functionality are rare. eTreat is focusing on chronic disease apps for arthritis, diabetes, chronic wounds, skin conditions, and musculoskeletal disorders. eTreat's customers are motivated by the desire to relieve discomfort and take control of chronic health issues. We empower these customers, including rural doctors and druggists, by giving them the ability to measure, analyze, track, and manage treatment of health issues, helping reduce discomfort and medical costs. Our 4 co-founders have expertise in developing world mobile banking services, medical image analysis, and bringing regulated medical devices to market. In May, we will showcase our first app for hand arthritis when we present at a national medical device conference in Vancouver. eTreat is looking for investors. To learn more, find us after the meeting or visit our website. Thanks.
Wonderful. Well, thank you very much. Let's give a round of applause to all 5. And I'll pass it back to you, Tim.
So we're just, if I can invite the panel to come up and join us, and if lightning pictures, you're free to take the front row as well if you like. And a very impressive set of presentations. I thought the panelists were smooth, articulate, and terrific, and it's great to see that we're getting some really good value and some good practice at articulating, and I hope all of you raise the money that you need to get done. The one thing I'm kind of curious, I have a question for Angela, and that is your CFO is Jeff Chop. Is that a nickname, or is he the guy in charge of the budget? There you go. Okay, without any further ado, I would like to invite Ian to take over, but also this is your opportunity for audience members only to put on your phones and get connected on Twitter. We have an industrial strength router in our midst, and if you just go to the Wi-Fi, find the Colony Mobile Wi-Fi, you can connect to that, and you'll be able to connect to the internet. Otherwise, you won't. We are in a nuclear bunker down here, and you probably won't get any cell phone reception anyways. So just say agreed, and what you're agreeing to is all of their terms, your firstborn child, and $3,000 sponsorship for the VEF. Without further ado, oh yes, VEF, digital health. Hashtag VEF digital health is, if you have any questions, put those up, and on the Twitter feed we will be able to collect those questions and hand them over and put them to the panel. So without further ado, please, Ian, thank you very much.
Great, thanks, Tim. What I'm going to do is I'm just going to introduce our panel here. And then I'm going to run through just a few data points I collected that I thought might be of interest to the crowd. And that should take us to around 7:10-ish. If I could ask you to hold your questions till then, and then just as Tim mentioned, we'll have our Q&A session. Let's meet our panel. Panelists, please wave your hand as I read out your bio, because I think you guys are mixed up the seats here. Okay, Dr. Brendan Byrne is the Vice President of TELUS Physician Solutions, a new business offering dedicated to helping physicians improve productivity and clinical outcomes. A practicing physician himself, Dr. Byrne is a graduate of Yale University and McGill's Faculty of Medicine. He has over 20 years of experience in family practice, including 7 years as the director of Columbia Medical Clinic. Prior to joining TELUS Health, Dr. Byrne founded Wolf Medical Systems, the largest cloud-based electronic medical record provider in Canada. He is recognized as a leading physician specialized in computing in North America. He has addressed many medical and computing conferences on the importance of leveraging data at the point of care. Welcome, Dr. Byrne. Nadeem Kassam is a director with Zynik Capital Corp. Nadeem is a serial entrepreneur and angel investor. Over the last decade, Nadeem has led Zynik Capital into new industries like healthcare, entertainment, and social media. Also, Nadeem is the founder and chief alliance officer of Basis, which creates very cool wellness devices and services that make getting healthy fun, social, and intuitive. Intel recently acquired Basis for a large number. Nadeem received a BA from Babson College and achieved recognition on campus as co-founder of the undergraduate incubator program. Nadeem is still involved with startups, but also with Zynik Capital has managed turnarounds, liquidations, and financings. Nadeem is passionate about all things that merge wellness and entertainment. When he's not using his Basis band to lower his heart rate and manage deep breathing sessions at the airport, Nadeem can be found running after his 2 young daughters while trying to convince them to eat green vegetables. Welcome, Nadeem. Richard Osborn, Managing Partner with RecapHealth Ventures, founded in 2011 to support increasing innovation from both within and outside the Canadian and U.S. public healthcare systems. RecapHealth is at present the only private non-governmental healthcare-focused venture fund in Canada. Prior to founding RecapHealth, Richard was a partner in Second City Capital, a co-founder and partner with Greenstone Venture Partners, and managed venture capital investments for 2 BDC funds. Over his career, Richard has led investments in more than 30 companies and transactions representing over $500 million in invested capital. In addition to acting as an investor, he has been an entrepreneur in a software company, Multiactive, and has led successful turnarounds in 2 healthcare-focused companies as interim COO and CFO. Richard is a frequent speaker on finance and social impact and has been named one of Vancouver's top 40 under 40. He is also a founder and past board member of BC Social Venture Partners and is currently launching a new fund of funds with several private and public partners. Welcome, Richard. Dr. Paul Terry, President and CEO of PHEMI Health Systems, currently serves on the board of directors for Providence Healthcare. Formerly, Paul was the Secretary, Treasurer, and Technology Advisor for the Michael Smith Foundation for Health Research. He was recently one of the entrepreneurs in residence at SFU Venture Labs and is currently a partner with Magellan Angel Partners. Prior to his experience in healthcare and venture capital, Paul was the CTO and co-founder of Octica-based Systems, a pioneer in high-performance computing, which was acquired by Cray. He was also the co-founder and CTO of Abatis Systems, which was acquired by Redback Networks. Paul was awarded Canada's top 40 under 40, holds an MBA from the Cranfield School of Management, a marketing diploma from the Chartered Institute of Marketing, a PhD in electrical engineering, and an honors bachelor's degree from the University of Liverpool. Welcome, Dr. Terry. John Waldron, Director of Enterprise Health Architecture and Security Reporting to the CIO at PHSA, is a health informatics professional, currently serving Vancouver Coast Health Authority, Providence Healthcare, and the Provincial Health Services Authority. His 15 years' experience encompasses both the private and public sectors of healthcare organizations, including work with a clinical software startup, a leading teaching hospital, and consulting with a variety of healthcare delivery organizations and vendors across North America. John favors a systems approach and clearly recognizes the value of information for better patient care and a better health system. He has presented at numerous conferences in the health informatics community. He is past president of the BC Health Informatics Management Professional Society and was a member of the 2014 Annual Conference Education Committee. John is a graduate of the University of Victoria School of Health Information Science. Welcome, John. I should also mention that John's here in a personal capacity, and some of his comments, or I should say his comments and views, only represent his personal opinion, not necessarily that of the PHSA. So you can show up to work tomorrow. So I love moderating these panels just because I get to throw some numbers at people. So I work at PwC. We have this Health Research Institute. It's based in the U.S., and they just recently released a study that I thought would be interesting just for the content this evening. So, of course, starting with some numbers, and apologies for some of the small font on the slides here, but in 2012, U.S. healthcare was a $3 trillion market. 2.8 of that is the U.S. healthcare system. The rest, the 267, is fitness and wellness management. And sorry, I should mention the name of this study is Healthcare's New Entrants, Who Will Be the Industry's Amazon.com. So there's some common themes in there, drive towards affordability and convenience, and that the center of gravity is shifting to the consumer. What does that fitness and wellness represent? These are all the things that are, I guess, they've put outside the healthcare system. I thought an interesting factoid here was there's almost U.S. per capita spending at $10,000 per person. I thought this was interesting as well. Big business is into healthcare. Of the 38 Fortune 50 companies with a major stake in healthcare, 24 are new entrants, not traditional healthcare providers. And look at the composition of some of those new entrants. 2 are automotive, including Ford, which is developing services for chronic condition management while driving. 8 are telecoms and technology companies, including Samsung, Apple, AT&T and its mHealth platform, which it was opened up to developers in 2012. Time Warner has a virtual visit experiment with the Cleveland Clinic caregivers so they can interact with patients through television using secure video technology. Now, this one's really hard to read. Sorry, a busy slide. But what I want to show here is the red arrows have a percentage inside them. Now, each percentage represents how many respondents reply that they would be very likely or somewhat likely to choose this option if it would cost less than the traditional healthcare choice. And each one of these is a digital healthcare option. The option is described under the percentage red arrow, as well as an estimate of the U.S. market share of such options. So I'm just going to read out a couple here. 34% would get an MRI at a clinic and a retail store or pharmacy. The market for that is $11.6 billion. 37% would have chemotherapy at home, $3.3 billion. I've circled in the bottom right corner there, out office and outpatient visits, $42 billion. So having care take place outside of the hospital or doctor's office, either through some technology attached or as part of your smartphone, which we saw in the lightning pitch, or a clinic in a retail store or pharmacy. Just a piece on consumer profiles that they're changing. Middle-aged consumers are the most likely, and there's an appetite that they're open to receive healthcare in new ways, provided the price is right. Consumers want the ability to shop for healthcare, and almost half would prefer to do so online. Now, I apologize for this next slide, but it's really busy, but it's got numbers on it. I'm an accountant by training, so I like the numbers aspect. But this one is from Booz & Co. Lots of great stats in here. I'll give you a minute to digest. I'll read out a couple of my favorites here. Physicians are 250% more likely to own a tablet than other consumers. In 2012, 85% of physicians owned or used a smartphone professionally. Granted, these are all U.S. numbers. 56% of doctors who use mobile devices say they expedite decision-making. 40% say they decrease time spent on administration. And interesting to note, only 28% of smartphone users and 18% of tablet users describe themselves as very satisfied with the quality of medical apps currently available. I came across an IDC Health Insights report by Alison Brooks called The Canadian Healthcare Landscape. I stole a few pieces here because I thought they would be of interest for tonight. This is from February 2013 and shows the deployment of mobile applications compared to all other industries. Now, these are Canadian numbers. So healthcare providers' future plans for mobility. Which of the following best describes your organization's stage or mobility in the next 12 months? And the first set of bars is what I draw your attention to. 31% of healthcare providers have no intention to deploy any mobile applications in the next 12 months compared to the industry average of 19%. Now, don't want to beat up on the healthcare system or anything like that, but I thought this was interesting in the lack of data that primary care providers have. I've circled what I thought would be some of the more interesting ones. Only 15% compared to 60% in the U.S. routinely receive and review patient satisfaction and experience data. Only 23% versus 47% in the U.S. routinely receive and review clinical outcome data. So it looks like we had a lightning pitch that might address that as well. So what are Canadians saying? And apologies, this is a bit of a commercial for our PwC healthcare team who recently did a Canadian study called Making Care Mobile, Shifting Perspective on the Virtualization of Care. The sort of overall results were Canadians are satisfied with the healthcare they receive and believe their security and privacy is well protected. And that's the first two bubbles on the slide there. But there are some areas for improvement: wait times and access to care. And I think I just included this last one here because it's got the name in the top right corner of where you can find that survey. So let's get back to our panel. And I guess where should we start? The title of the session tonight is Buying and Selling in Digital Health. So let's start there. And Rich, I see you've got the end. Let's start with you and work your way back. I've introduced our panelists, but I haven't introduced their organizations. Could I ask each of you to introduce your organization and how you fit into the digital health landscape? Specifically, are you a buyer or a seller?
Sure. Well, I guess it depends if we've invested or not.
And which hat you're wearing.
And which hat I'm wearing, right. Yeah. So good evening, everyone. I was just taking some notes here. There's some interesting stuff maybe we'll come back to through the panel. But RecapHealth, my organization, is a Vancouver-based investor and catalyst for Canadian-based health and wellness companies. So the investor part is easy. By catalyst, we mean we're playing an active role in bringing together constituents from the public sector, the private sector, capital, entrepreneurs. And we have an organization called the Health Innovations Group, which you can look for some news on that coming up in a few weeks. But we're actively looking to play more than just an investor role in helping catalyze the sector. And it's great to see the turnout here. I don't know how many people this is, but I bet you if you had this 2 years ago, you would have had a third or less of the people in the room. So it's great to see. So we've been in business about 3.5 years. We've made 9 investments. We are what's called stage agnostic. So we'll do anything from kind of a couple guys with an idea, a couple people with an idea, right up to public companies. So relatively rare. And our thesis was basically that to focus on healthcare was still broad enough. We didn't want to limit ourselves in terms of the stage of opportunities that we pursue. Just a little bit of color. So we've done companies you might have heard of. So Medio was an example of a company that's kind of in the early stage, the telehealth sector. Excuse me. We did a company called ThoughtWire, which is a growth stage company based in user experience and workflow based in Toronto. And then a company called Vision Critical, which a lot of you would say, well, I've heard of that, but that's not a healthcare company. So we made an investment in that because one of the growth areas for them is in citizen engagement and working with the public sector, organizations, health authorities, et cetera, to better define the clinical services and offerings that they have and engage populations. And as we saw in some of those slides, people's are kind of their lack of appreciation for the trade-offs between costs and services that the public healthcare system has to offer is an important one. So our thesis was simple. Three things: costs, demographics, and technology are all driving changes. And 20 years ago, one quick stat, 32 cents of every government dollar was spent on healthcare. Today it's 46 cents, and if we continue at pace, it'll be 75 cents in 15 years. And so you can say, well, we want the healthcare system to change, and we've got an older demographic coming, we need to have it in place. The reality is education, infrastructure, social services, all that stuff is going to get squeezed to zero. I mean, the analogy, software is eating the world, healthcare is eating budgets. But I think the most important trend, and then I'll stop here, is all of those are important and they're all real, but they're all incidental. I think the biggest change that's going on in the healthcare system is patients starting to view themselves more as consumers. And they're starting to say, you know what, the status quo, the experience I just had waiting 17 weeks for this or having to go through this process, it's not acceptable. I don't deal with it. I won't accept it in any other facet of my life. This is literally the most important part of my life, and I don't want to deal with a system that doesn't treat me more as a consumer. So that's kind of where we see the major trends. And I don't think digital health is as important as just health trends in general, and I think that's a major one.
Thank you. Nadeem?
Sure. So Nadeem Kassam from Zynik Capital. Zynik Capital is traditionally a distressed asset investor. We look at companies in all kinds of sectors. It's a family business. My focus for the last 10 years has been primarily on early stage companies. I lead the angel investing group and do anything up to a Series A. I'm absolutely an entrepreneur first. I founded quite a few companies. Most of them failed. But most recently, I founded Basis Science in 2004. Did all the R&D out of Vancouver and some out of Shenzhen, China. In 2010, moved to San Francisco, moved to Silicon Valley, raised a couple institutional rounds, built a pretty rock star team, launched a product, took some market share, and sold the company to Intel for close to $150 million. Promised my wife that we'd move back to Vancouver as soon as that was done. And we did. My gorgeous wife is sitting in the row here. And so we moved back, and I'm focused now on helping entrepreneurs in their early stages. My specialty is definitely raising capital and building from founding to around that Series A stage. Definitely still operating as an entrepreneur. Founded my next company. It's called BioBeats. We're merging digital healthcare and music. Looking at basically, the sensors are everywhere. Sensors are coming fast, whether they be on our bodies, whether they be in our environments, and this data is going to flow. What's this data going to do for our entertainment? For when your fridge is talking to your TV and your home security system is talking to your body. How can we manipulate that data, and how can it work for us? So that's Zynik Capital. It's myself. I'm definitely looking for early stage companies, looking for passionate founders and some high growth potential.
Thank you, Nadeem. Paul?
My name is Paul Terry. I'm the CEO of PHEMI, I guess. So I'm still there. They haven't fired me yet. This is actually my sixth startup, as it turns out. I've been doing this for 30 years. I started from the beginning of the internet, back in data networks times, went through firewalls and cloud computing, supercomputing, and I retired in 2007. And so I went skiing for a year, and then in 2010 I joined the board of a hospital. And then seeing from the inside, I'm on the quality committee of the board, seeing how healthcare works. Every 6 weeks we see all the data. Decided to go back into the saddle and joined a company that was founded by some physicians and brought my supercomputing team back. And so we now do PHEMI. So PHEMI does big data. So we collect and collate anything on data, store it, secure it, do privacy and governance, analyze it, and distribute it. That's what we do. So think of big data companies, Google, LinkedIn, Facebook, all these types, all big data, and think about basically the use of data as a service. And so this is what we're kind of dedicated to. And in terms of the questions you asked, where do we start? US and Canada are different. So we're going to get into in a minute, I guess, the difference between the two and what it means to you guys who are trying to start companies in healthcare. The healthcare industry in the US is 4 times the size of the retail banking industry. So it's a huge industry over there. And and small companies are $1 billion. So to be in healthcare in the US is a really, really big thing. And it's all changing. They just changed the law in the US. And so the center of gravity has just moved straight to the consumer away from the institutions. And that's the biggest change in healthcare. So I guess we'll get into that in the next 20 minutes.
Great. Thanks, Paul. John?
John Waldron with Provincial Health Services Authority. I work directly with the Information Management, Information Technology Services Group, and we manage all the hospitals around Greater Vancouver. In fact, the whole span or continuum of care across Greater Vancouver, up the Sunshine Coast and Sea to Sky corridor, as well as a number of the provincial systems in play. I represent from the perspective of the buyer in this context. For background, I've worked inside these large institutions for a number of years, currently in an employee capacity, in the past as a consulting capacity. Had the luxury of spending 5 years consulting for the public health hospitals of New York City at a time when the big focus in healthcare was all about chronic disease management. So, 5 years ago, that was the hot topic. And prior to that, I had the luxury of working with an overly ambitious startup trying to build out an electronic health record around the dot-com boom of the 2000. It's funny to hear the discussion in these contexts where we talk about things like digital health and wearable technology, biosensors, very innovative topics. My concern on a daily basis is how do I uniquely identify a patient? We can't do that today across the Lower Mainland with with any degree of reliability. How do I identify providers? I really don't know where my source of truth is for a list of providers, as silly as that may seem, as seemingly benign problem as that may seem. That's a huge issue for us. And those are these kind of foundational elements that we're struggling to get in place while all the sexy stuff gets all the attention. And, for the startups and for those looking to come into the healthcare market, and as some of the evidence shows, this marketplace is growing like crazy. I mean, we thought it was really big in the 90s, but now it's a little overwhelming. Look at some of these foundational issues. Either those foundational issues will break our systems, just won't allow us to play with any reasonable degree of effectiveness, and we'll look to the private sector to shore up those gaps and deliver solutions that work for us. The way we're structured today, it doesn't foster that sort of innovation amongst industry and in community. It's a very internal classic bureaucracy or hierarchical structure where we almost purport to know what's best for ourselves and not necessarily looking actively to our community, to our patients, and ultimately our customers to really understand what does our customer need? What are they looking for? Our battles are, and if you look at our big project and one of the biggest investments in healthcare in BC's history, which is just kicked off recently this spring. You can look it up on cstproject.ca is the website. That purports to, if you look at it rather cynically, we're doing the big ERP implementation, and we think that's going to solve our problems over the next 5 years with regards to capturing information and using it effectively to support the delivery of patient care and ultimately to positively impact patients. We see on a day-to-day basis that the more viable solutions seem to be more pragmatic, smaller, attacking specific problems and getting traction from there for spread. And there's nothing like testimonials from physicians or patients really to push those technologies or make them spread. So with that.
Thanks, John. Brendan.
So I'm a practicing family doctor, and actually it was interesting when I was looking at the slides there. If you looked at one of the slides, what's the toughest market to pick? The mobile slide. Doctors that are thinking top bar, Canadian doctors aren't interested in this stuff. So 20 years ago, I decided to get into digital health, and it's been a long journey that I joke, never confuse a clear vision with a short distance. And I think that, for entrepreneurs in the audience, I would actually really drive that home, especially in healthcare, especially in this country. So, but nonetheless, the value of what we're trying to do is tremendous. I got into this because as a family doc, I came out of my training and I started working in practices, and I realized we spent all this money gathering information and we put it into these paper charts and did nothing with it. And I thought, why can't we leverage the information that we gather and leverage it at the point of care so that we actually could provide some tools to the doctors to make better decisions at the point of care? Why don't we do that for patients? Why don't we take the data that's theirs and make it useful? What I realized along the journey was, first you had to get reach. You had to actually, get doctors to get on board and get applications. You actually have to get reach with patients as well. And so, I built an EMR company. I was joking to somebody earlier that, the good part during the .com boom was I didn't know how to run a business, because otherwise I would have had a great story, raised a couple $1 million, and gone out of business in 2 years because there was no market for what I was doing. So fortunately, I didn't know how to run a business, and I stumbled along and bumped along until there was a market actually available and could build a business. That took far longer than my wife ever anticipated, and in February 2012, the company I'd built, Wolf Medical, was acquired by TELUS. I spent the last 2 years, other than acquiring companies, we've done 3 other acquisitions. So other than acquiring companies, what I've done is explain to doctors why the phone company bought their EMR, which is an interesting discussion, but it talks to some of the foundational capabilities that we actually need to have in the country, in the private sector, around digital health. So there's a lot to go on tonight and a lot of things to discuss. But if you're looking at starting companies, there could be no more exciting time than right now. We're just at the cusp of some emerging trends, right? So you think about what I've done with clinical informatics. That's starting to merge into a pool of genomic data, the personalized self, the monitoring data coming forward. That intersection of that data is not manageable by our healthcare system. I do not believe that the public healthcare system has any clue what to do, and I know as a doctor I don't have a clue what to do. We need really smart people who can actually start to sort through that data, build tools for doctors at the point of care, build tools for patients to manage their own care. So I think it's a fantastic time to be looking at this and talking about this.
Great, thank you, Brendan. I think you've touched on, and then some of our other panelists have touched on just what an opportune time it is. Maybe we go into that a little deeper about the landscape for a seller. And what I mean by a seller is, a BC technology company or a Canadian technology company. What's that financing landscape look like? I know, Paul, you recently closed around, but what is that? And, Richard, I know you can chime in here as well. But what does that look like in terms of where we are now, say, compared to 5 years ago?
Sure. I founded my company in 2004 as a consumer hardware company, and back in the day there was no such thing as crowdfunding, and as we've mentioned, as Rich mentioned, the room would have been a third full, and especially financing and raising money out of a place like Vancouver with such a small population was very difficult. And so, as was said, there's no better time than now. The market is caught up. Digital healthcare is a big buzzword, and people are investing left, right, and center. You see automotive companies jumping in, and all kinds of interesting companies jumping in. So not just from a venture capital perspective, corporate venture, and all kinds of interesting companies like Time Warner and on are investing in this space. And so, to be a consumer hardware company in this day and age, at this point, and validating your ideas through places like crowdfunding and having all these amazing accelerators like Sanitron, it's amazing to be starting a company right now versus 10 or 20 years ago. I feel your pain, man.
Yeah, timing is everything, right? So first of all, there's a difference in health and wellness, right? They're just two different things. In the US, almost every venture capital organization has exactly one investment in health or wellness, not two or three or four. I think there's only about 3 or 4 venture capitalists who actually have more than one investment. So everybody is putting money down on the whole market, and nobody putting a second or third yet. We haven't really seen the billion-dollar exit from a wellness company yet. As soon as we do, you're going to see a land rush to invest in those wellness companies. The closest we got to, I think, is WebMD, which is essentially an internet version of information for docs, or for you on the basis of docs, which is a very straightforward thing. And they did actually very well. So we're starting to see the valuations increase. We're seeing a rush to it, but they're being very conservative about, I'll just invest in one. Wellness is much easier than health. Health has time constants that'll kill you. It literally can go years before you can get a health product in. Wellness, you can be in and out in 3 or 4 months. And so there's a movement towards wellness because it has a lower barrier to entry, which means it's also a lot busier than the health organizations. Having said all of that, the health in the US has just changed. Right? So the health system in the US all changed last October with the introduction of the HITECH Act to the HIPAA, HITECH Amendment to the HIPAA Act, which changes the information. It used to be the ownership of the information was with the institution. Now it's with the individual. So you are now obligated, if you're an institution, to give the data to an individual if they ask for it. And if you don't give it, it's $1 million per instance fine. So now I can ask for information, I can get it. So I can go to apps to actually analyze my medical information. So this is the attempt of the Obama administration to break down the barrier between the competitive advantage of information held by an institution and give it into the hands of the consumer. So we're going to see a plethora of apps coming out now in the US around your health information, but actually in the wellness context. And that's the big change.
Yeah, I might just add a couple things. I think probably consistent in this whole discussion will be toggling between the US and Canada as very different markets. And so leaving the US aside just for a second, even in Canada, we really have about 12 or 13 jurisdictions, right? We have the feds and then we have the provinces. So depending on what you're trying to do, you have to sell basically to 13 or more. If you're selling the health authorities, then you add 5 in BC across. So you're constantly segmenting your market down. And then I would say there's a very, very big difference between B2C and B2B. And maybe in some cases it's B2B to C or B2C to B or whatever. But the idea is depending on the organization that you're trying to sell into, the organization that you build and staff is very, very different. Paul referenced the number of kind of drive-by investors in healthcare, and I think that's true. there was 200 companies last year that raised more than $2 million, and there was only 10 venture firms that invested in more than one deal. So there's a real kind of everybody's trying it, everybody's dipping their toe in, but there's not a lot of specialized service firms doing it. What I worry about right now, given all of this, and not to dampen any enthusiasm here, is I worry about a bit of a bubble. There is a lot of, especially in wellness, deeper, harder healthcare stuff is a bit different, but there's a lot of wellness apps. There's over 100,000 now apparently on the iTunes store. And, capital is available. Nadeem mentioned, crowdsourcing and things like that. That's great, but there's a big shakeout. And 50% of all the capital that went into the space went into seed and Series A deals. So if you talk about a funding kind of gap, it's starting to happen at the Series B level. And that is a real problem because companies then come to, even with momentum, they come to the market and they say, where's the capital? And it's just not there. So there's going to be a lot of tiers. A few IPOs ago, Castlight Health, those of you who follow the space, right? Investors always look at IPOs and what's the public market appetite. Castlight doesn't matter. It's a digital health company. They had $13 million in revenue, $13 million. And at one point, their market cap was $3.2 billion. That's 107 times revenue. Now it's come off a bit. It's a very modestly priced 60 times revenue today. Right. Real steal. But the point is that smells to me a little bit like a bubble.
Bubblish, yeah. Interesting. So we've talked a little bit about seller landscape, and I know John talked about you're not really sure how they identify suppliers and all that. I'd love to kind of bounce that question around. What is the buyer side, the hospitals, the individuals? What does that landscape look like? How are they choosing and determining suppliers, and what's having success? And John, I don't know, maybe we'll let you think about it a bit and give Brendan the torch here to kind of think that one through.
Well, the interesting part of my journey has been buyers have been physicians in Canada, and my reality has been I've been selling to clinics that are average size in Canada of 3.7 doctors. The nice part is once you build a business, no one of your customers is more than 0.5% of your total revenue. So it's interesting from that perspective. But the challenge is, I'll go back a little bit around kind of the marketplace for Canada, because my focus has been Canada, and TELUS's focus is in Canada, and our health play is completely a Canadian health play. But there are actually 14 different jurisdictions when you include the provinces, the territories, and the federal government, and what that does to our market is really tough. In one respect, it makes it so it's hard to go province by province. It also puts up barriers though to other companies coming from the U.S. up here, and that's an interesting opportunity for Canadians, especially in a space where there may be a bubble. And I think when you're looking at the market, trying to understand and create value, and where that value is going to go, it's not a traditional, create the value for John over here in PHSA and sell the application. We're increasingly looking at, so at TELUS our strategy is a 3-step strategy. So first part of the strategy is we've got to get enough reach. So we have to have reach to providers, and we've got 40% of physicians now and a third of the pharmacists in the country. But a big part of it is then connecting. So you connect and create collaboration services. Those services are no longer services that we're selling to an organization on the basis that they've got to invest a massive bunch of capital. They're services like electronic requisitions that you can go to a big lab company and say, that thing that costs you $7 to process, we can make a transactional value of that for $1. And by the way, when we do that, we can create an application that's far more effective than the analog piece that we replaced. So I think that's part of what we're seeing as a change is rather than selling applications, which is traditionally where a lot of health has been, it's now starting to sell services. Step 3 of our strategy is around outcomes, and it's the most nebulous part of our strategy at this point, because it's dependent on reach. We've got phenomenal data sets, but how do you leverage them, and how do you turn that into those outcomes into meaningful, monetizable product? But again, I think it's going to be linked to an observation that somebody made around one of our management retreats, which was, the health IT budget continues to shrink. It gets smaller and smaller and smaller, while the health budget continues to increase. So you really kind of don't want to be viewed as a health IT company. You want to be viewed as a healthcare company, and that your problem you're solving is the overall medication spend rather than the IT, spend in if you're in medication management. And that's governed a lot of our thinking of how to approach outcomes. And I throw out there, and this one gets a lot of rolled eyes, but I throw out there from a TELUS perspective, we expect to sell outcomes on the basis of one day we'll go in and we'll have a contract with a health authority to decrease emergency visits for a condition. That's it. How we do that will be wrapped up in a managed service, but we'll be actually selling the outcomes. And if we sell the outcomes, we'll get a monetary benefit, as will the system. And if we don't sell the outcome, we've invested the capital and the regions out. So that one's a little bit out there, but I think that you can see kind of how I think things are trending away from kind of the traditional applications, more to services, and then trying to monetize those services.
I really find that approach appealing, to monetize the outcomes or tie your compensation to the outcomes. It certainly would, I think, create much more innovative solutions delivered as services. What we've managed to construct, probably quite unintentionally in the healthcare sector, is a large, overly bureaucratic, highly sensitive to transparency procurement model. We have a designated body, Health Shared Services of British Columbia, that's designated to do the procurements on behalf of the health authorities, not just in the information technology, but across supplies, buildings, what have you. And in some contexts, that may work well, that model. I'm most familiar with the procurement of information technology. So specifically, we have struggled to bring innovation into play into our environment. As Paul can attest to, there's been huge challenges in having an innovative solution that solves a specific problem brought into our environment without going through a lot of gyrations around due diligence and is it request for proposals, or other words, going out to market and asking for solicit bids on solutions that are prescriptive. So if you take Brendan's example of packaging an outcome, we wouldn't go to market for that today. We would go to the market and say, some opening paragraph about, we have this problem about wait times in our AD and backlogs, and here's some long verbose description about it. And by page 10, we get to the point of saying, actually, we need to solve this problem. And for the next 40 pages, we'll tell you exactly what we need to solve this problem. Now, when you think about it, are we engineers? Well, not really. Like, we are folks working in the public sector, trying to do our best every day, showing up to work, trying to make a difference. We have some expertise we bring to the table. It's usually a highly collaborative effort, cross-professional representation, the physicians. Hopefully, if we get the donuts on the table, they show up.
The wellness app there.
Yeah, the wellness app. These days it's like, I'll let you get that iPad on the network if you come to my meeting. And we get some bureaucrats and some IT folks and some representatives, some administrators from the business, and we get together under the guidance of procurement, and we blow out this huge document. We post it up ultimately on BC Bid. We hope that all the entrepreneurs are actively canvassing and watching BC Bid on a daily basis for the next hot posting, and then spending the next 6 months or so going through crunching out a response to an RFP. And I'm not sure the context of the audience, but if you've ever been through the experience of responding to one of these, boy, it's a tough challenge, and it really cuts a number of smaller organizations out of the market and leaves it for organizations that can survive the sales cycle, this really long sales cycle. Not months, sometimes years, literally. And ultimately, the procurement model gains momentum, and lots of complexity gets sort of baked into the process. And evaluations and shortlists culminate in a vendor selection. and or preferred vendor selection, in which case you enter negotiation. And that's another, can be a long period. The health authorities in the province, by virtue of its size and being in the public sector, has some artillery it brings to the table in terms of being able to walk away from that deal really with no harm done to themselves, and presumably a lot of cycles, or that sort of model really keeps out the smaller business, the business that can't convince their investors to just wait 12 months as we try and close this one deal. And then to Brennan's point about these selling into different jurisdictions, you may sell into PHSA, or you may sell in and be fortunate enough to be selected as the preferred solution for the province, and thus giving the right of any health authority to take that solution without going to market, which rarely happens, even though that model is in place. We prefer to go to market because we're all unique, right? You know, the North is different than the island, is different than Vancouver, is different from than Ontario and Alberta, and by golly, you must meet all our requirements. So we'll list 40 requirements that are unique to us, but to the vendor, to the person selling that product, all of a sudden they have to fork their code. And when you do that across Canada, good luck as a small business trying to support 14 different versions of your code base as the requirements are churning in. You may as well just spin it off 14 times and hope for the best, and have little entities or something deal with it. Canada has made an effort through the Canada Health Infoway organization founded by the provinces collectively. I think it's all the ministers of health that sit on the board of directors of Infoway. And the idea there was, if we throw $1 billion at the problem, we can maybe come up with something called a Pan-Canadian Health Record. And they unleashed the engineers and made lots of box diagrams with arrows and lines and stuff, and sold this concept that we can achieve this through targeted investments. Well, we're now 10 plus years later. We don't have a pan-Canadian health record. We barely have a pan-regional health record, and it's for systems like Wolf and under the EMR guys that we have some hope of having records that span more than one organization, be it a doctor's office or a large organization, let alone information sharing between provinces, which would be really nice to have. In the States, we see it as a little more viable. As Paul talked about, there's some programs, national programs there that have been recently, over the past few years, have been growing around meaningful use and how to use technology in a way, getting compensated for using technology effectively in the context of care delivery, not just the Infoway approach was more like, wow, that sounds like a great idea. Why don't we fund that cool thing that, got bandied about for a year? So we saw things like a massive investment in radiology systems in London, Ontario, or in the southwestern Ontario region. We saw massive investments in drug systems in Newfoundland, massive investments here in BC under the banner of eHealth, which resulted in a big honking database that stores all our lab orders and results, but only those generated in the public labs. So doesn't quite get them all, but these are that program continues to fund investments, but the investments they're making are not in, more recently, they're in smaller organizations, I think, or they're trying to recognize that there's more innovation to be had with smaller organizations. Traditionally, they're the large investments. And that really, we actively, myself actively trying to campaign with our organizations to try and find models in which to foster innovation. We find research as a vehicle to get us there, and we want to research just with partnering with researchers is okay, but we also want to bring in the private sector, be it the big companies like TELUS that have the telecom networks, that maybe have home monitoring solutions in play, partner with smaller businesses or smaller ventures that have more of the innovative mind thought and the agility to bring these solutions to market, and to do it in the context of a research initiative such that it really leaves us as a public entity to say, we're not interested in making money from this. I don't really care if I have the shares or not. Are patients better off? Did someone show up to the ED and get treated in a timely fashion? Or even better, they never showed up to the ED because we caught them as they had the challenge or whatever, an incident at home, and redirected them to the appropriate care setting, which in many cases is not the emergency.
So, John, you've highlighted a barrier to entry here, kind of being the procurement model. I'd be interested in Paul or Nadeem if how have you dealt with that in terms of your businesses? What strategies are you employing?
Change the procurement model. I'm working on it. No, it's a big issue. It's small companies find it very difficult to enter any form of government because government has this very long, very laborious, not just healthcare, it's all over government. So government are actively attempting right now to change the procurement models to allow innovation to take place. That's an active program going on at the Ministry of Innovation. So there are ways that they're trying to move forward. I was going to say on the innovation thing, hospitals, I'm a big fan of physics, so physics works in my experience. And so as the cost of healthcare increases, essentially the BC government, if you want to call BC, is a healthcare government. I mean, half of what it does is healthcare at the cost of everything else in BC. And that's just going to increase. So the natural forces that are in place are to try to contain that cost. Now, it costs $100,000 a day to put somebody in a bed in a hospital. It costs $5,000 a day for ambulatory care, which is the day clinics that you come in and out. It costs $30 an hour or so for GPs in primary care, and it costs essentially nothing to put people at home. So the technology to try to keep people at home and to push care down to primary care and to homes is actually an active program that's going on to keep people out of hospitals. Notwithstanding the fact when people go to hospital, they have adverse events and so forth, and we're trying to keep them in the general area. So innovations to do with trying to get the continuum care down to people at home are actually very well received in BC generally. At the Province Healthcare, we actually now have an innovation subcommittee who live alongside the Finance and Audit Committee, alongside the Governance Committee, alongside the Quality Committee at the Board of Directors. So they understand that we have to innovate somehow, some way, whether that's a new procedure, a new way of doing something, a new test, an information method. That's what we're trying to invest in and trying to get everybody going. I've often said that, the nice thing about the hospitals is they actually see the customers, the patients, right? They actually get them, but nobody can get into the hospitals to actually sort of make it better. So breaking down the barriers between the hospitals and anybody who actually wants to add or subtract something to the health is going to be a big advantage to everybody. And it'll have to happen because they just cannot sustain this ever-increasing cost as people get older and so forth and so on. That said, what's starting to happen now is we're starting to concentrate healthcare away from the hospital into a disease-specific healthcare methods, such as HIV or cardiac or prostate cancer. Cancer Institute is a good example of this, children and women. And so we're getting disease-specific networks that can be optimized around diseases rather than around hospital and the old notion of buildings where I treat everybody. So that's kind of how the Canadians are going. In America, it's not about healthcare at all. It's an economics issue. It's all a straight cost issue. Do not confuse healthcare with economics in America. It's all about money. And, they spend currently about twice what we spend per capita on healthcare. And it's all driven by money. How do I get the procedures done? How do I get the people out? How don't I do readmissions? They're operating on 2% gross margin, most of the hospitals. And so if they get it wrong, they just go out of business, which is causing a great consolidation of health organizations in America right now, all with different information systems, so they can't talk to each other, which is problematic, So America is actually an easier place because it's all about money. So return on investment means something in America. Return on investment as a proposition for business in Canada means nothing. So actually they talk about soft return on investment, because if I save money in X, Y, or Z, only two things are going to happen. Either the waiting list will go down, I can see more people per unit time, or I just close the group for 2 days a week, and neither of them matter in a public healthcare system, oddly, right? So,
I'm just going to jump in there because we had a conversation with Alberta Health around this, and just talking about this trend of trying to do more. So home health monitoring or home health care is a big focus in BC, and it hasn't been in Alberta. And the assistant deputy minister just looked at us and said, but we can't look at it that way. It's just two different parts of what we do, right? So saving money over there doesn't help me over here. And stunning from, if a taxpayer was in the room, stunning from that perspective. But those are the kinds of, funny conversations that you get that aren't return on investment conversations in Canada.
From my perspective, and as an entrepreneur with extreme lack of patience, I went directly to the consumer and avoided any agencies or procurement models. And the theory being that if you can go and build a beautiful consumer product or app and get engagement, companies like ours, like Basis, like Fitbit and whatnot, they went to the consumer first, they got the traction, and now we're seeing immense growth from a corporate perspective, from a corporate wellness perspective. And once that starts happening, insurance companies want to jump on board and start paying for it. And so I took it, had the luxury of taking it maybe directly to the consumer and avoiding it altogether and having them come to me.
It's interesting because I don't think the investor community has either caught up to that, or I don't know if you can hear me or not.
Yell.
We can. They can hear
you. Can hear me? Okay. I was just saying, I don't know if the investor community has caught up to that. Something close to 80% of the money flows to B2B business models. And I think there's something kind of binary about a B2C business. It either works and it blows up, on the good side, or blows up on the downside. And so I think it's tougher for people to kind of get a handle on how do you scale and what are the gates and what do you, how do you scale a business in the B2B market. But again, if we're just talking about Canada for a second, the problem with the hospitals, there's three big major cost centers for healthcare. There's no secret. There's drugs, there's doctors, and then there's the hospitals, doctors and nurses. No offense. And those are well known, and those costs have been increasing well above the costs of inflation, as we've talked about. Bending the cost curve typically means, in government parlance, that they restrict access. So guess who suffers? Well, the patient suffers, the very person you're trying to protect in the long run. So what I think is starting to happen, and John, I think you alluded to this a little bit, is people are recognizing that a hospital is the worst form to deliver all of the different forms of healthcare. So they're pulling apart the various business models. If you look at a hospital, it's like a consulting service. You're trying to find out what's wrong with somebody. It's a job shop. You're trying to do knees and hips and all that stuff. There's research. There's all these different things which in private practice, in private industries, you'd never conflate all of those business models. So they're trying to say, okay, well, wait a minute. Let's put the job shop over here separately, maybe across the street, and let's do the research over here, and let's do all that stuff. When that happens and when that trend accelerates, I think vendors, like the entrepreneurs and the people who fund them, are going to have an easier time because they're not going to have the guy who says, well, wait a minute, I don't benefit from a cost efficiency over here, because the cost efficiency and the service delivery and the patient outcome will be much tighter aligned. We've been dumping on the system a bit, but there are some glimmers of hope.
One other thing we haven't touched on that I think might be important to bring out is that healthcare is a politician killer, right? And there are very few politicians that can do good things in healthcare and run on it. Ironically, Mitt Romney could have potentially been one of them, but he ran on the other side of his own healthcare achievements, right? Like it's just so the risk averse nature of the politicians running our system permeates all the way through the system. And the procurement process, they're so frightened around some of these innovations. Are they is there something bad going to happen from this? Because there's almost a belief that nothing good can happen. So kicking the can down the road, at least it's not it's not bad for me.
It's a zero-sum game.
Yeah.
Mm-hmm. So that's an interesting point. So I mean, maybe just following along with that, what is the role of government here? And maybe I'll just add anecdotally, I understand in the U.S., sorry, I'm a tax person, there's an actual tax incentive for organizations that adopt e-health and digitized records. maybe along that lines, Brendan, do you see anything like that coming down the pipe, or that type of government involvement?
Well, I think I think governments are looking how to get out from the traditional procurement and get to outcomes, because that potentially the win-win in terms of risk. They can shift some risk. They can at least shift the financial risk so that you don't have. Ontario has been paralyzed by these e-health projects that have gone nowhere, right? And there are many more across the country. So I think the shift to funding outcomes is one that they're interested in.
Right.
Still haven't seen that in a major way.
Right.
Funding practitioners for outcomes. There's always challenges. The UK did that with QoF, huge amounts of money. Did it really make the difference for patients, or were they just managed to the outcomes that were selected? Right. So it's a bit of a complicated business. But I think that there is an appetite on that end.
The English are probably the most advanced at the moment. In England, they had a scheme whereby, rather than seeing hospitals as cost centres, in which case what you do is take cost out. You can never add value, just taking cost out. The UK decided to give some of the hospitals a cost value set of money. So as an example, one hospital said, well, we have handicapped people that start as children and grow up, and every year we have to throw away the wheelchair and have another wheelchair. So what they did, the hospital went for RFPs to people to invent new technology to try and solve that as a problem. So they knew what the problem was, didn't know what the answer was, but then encouraged 3 or 4 companies to bid. They chose one, didn't have an answer. Then they paid them to make actually a wheelchair that all the bits came apart, and you just took bits off and added them on. The wheelchair just grew with the child as the child got older. That company then took that idea and then marketed it generally. So the hospital won. It got what it wanted. It provided the problem. The open market provided the solution, and then they were free to market it. That's a really good strategy, because the hospitals that understand what the problem is, entrepreneurs, as good as they are, probably don't. And they're probably trying to get a technology and say, well, I think this will solve it. And the hospital say, well, that really didn't really do much for me. But if you could do that over there or move that to the right 4 feet, that would be ideal. So the UK are doing very well in that, and that's a public healthcare system. But we can only do that if there's political change to say, here's a body of money, go invest, go play with it.
Go ahead, Rich, if you have something to add there.
I was just following on that. So I think there are clinical commissioning groups in the UK which are related to that. So I would say there's 2 things. One is standardizing information gathering, like, every other industry does it. A unit is a unit is a unit. We resist it vehemently in Canada, right? Like, why can't we know, and why can't I look at a website, what's a wait time in BC versus Alberta or in Vancouver versus Kits versus, different areas in Vancouver. So the system really resists standard objective measurement. And the really heretical point would be to say, well, how about we reward people like health authorities and hospital CEOs with the actual performance of their hospital under those specific targets? So how about a CEO makes less money? Like the CEO of I won't say which one, but a local hospital, he makes $700,000 a year. I mean, I think there should be some variable component of that based on how it's delivering the service. The other thing is, I think government can play, because this is a social contract, right? Health. It's probably the most fundamental social contract. I think government can do a lot more in catalyzing other sources of capital. So less IRR sensitive money, philanthropic money, foundations, endowments, that come to play and that can drive innovation in a way that just IRR driven capital doesn't do. And when you do that, everybody benefits. And there is more and more individual investor interest in supporting companies. It's called social impact. Those of you who are interested, lots of interesting work going on in the field. And I think the government can play a role through tax incentives and other things to pull capital in to support these companies in that way.
Right.
Yeah, I think you would be surprised at the data we do collect. I mean, I sit on the quality committee, and we collect data like how hot are the meals that go to the patients, what's the average delivery time per meal, how many holes in the sheets that actually are in the thing. That's simple ones. Adverse events. How many people do we actually kill in the hospital against how many we expect to kill, for example? These are actually required metrics to be accredited as a hospital in Canada. So there are some, there's about 250 of them, actual pieces of data. But to your point, we don't collect everything. Technology allows us to collect everything, but we don't. So we have no real telemetry, for example. You go to the ICU, you'll still find a big sheet of paper that's about this big by this big, and somebody writes in every 5 minutes of every day of every hour, every parameter off this particular bed, where it wouldn't be it's a high school problem to connect them to one aggregator and put it into a computer. I mean, it's not that difficult, but we don't do that. So it's still cheaper for us to actually get people to write on pieces of paper than it is to actually deploy the technology. Wow. And that's a problem. Pieces of paper actually work quite well. They're very high resolution. They people can see them. They're quite movable. Privacy and security quite like pieces of paper. They don't get lost that easily, and you can't send them across the internet. You can't easily put them on Facebook type of thing. So.
I think for this audience, one of the comments that you made, I think, was actually really astute around, our health authorities and governments are actually, they know the problems, right? The people, right? They know, because often, I'm impatient entrepreneur, and why can't? And you talk, they know the problem as well, or better, in fact, and entrepreneurs often have solutions for which there is no problem. Like how many apps do you see and you go, what a great solution? Not sure what problem it solves, but so I think the role of especially in Canada could very much be around if we aligned it where we know the problems, right? They're staring us in the face as you look at demographic shifts and trends.
From an entrepreneur's perspective, the funding issue is quite a problem. Coming out of Canada or out of BC specifically, and to your point of government knowing that and creating solutions, it was fantastic programs in BC around anything from BC investor tax credits, where angel investors get 30% of their money back, to the Shred program, where you get incredible dollars back for your R&D programs and IRAP. These programs don't exist in so many places, especially throughout the U.S. And so, your early days as an entrepreneur here don't have to be as rough as they sound. It's a good place to found a company. Absolutely.
The panel's starting to talk about tax now, so I know it's time to open up the floor for questions. And I forgot to check just how we get the tweets up on the screen, but maybe while we're doing that, if anybody has a question, please raise your hand. We've got a couple of microphones floating around. Yes, so hashtag VEF Digital Health, if you'd like to tweet out a question. Great, looks like we've got one in the front row.
So as someone developing mobile apps, I'm kind of interested in this, and I think there's a whole bunch of decentralized healthcare happening in the personal healthcare, the wellness apps. How does this information intersect with the health record generated in the physician's office, the health records generated from the labs, and with the health records generated from the hospitals, and with the health records that maybe go to insurance companies? How do we see that meshing over the next few years?
Oh, maybe I can give PwC a shameless a plug here. Will Falk's got a great paradigm for apps that frankly really resonated with me, and it was looking at it from the perspective of think of your pharmacy, right? So you've got things that are just on the shelf, so anybody can pick them off, right? And then you've got the over-the-counter stuff like cough medicine, which you might read the instruction before you give your kid cough medicine. You might even talk to your doctor about giving your kid cough medicine, but nonetheless, it's over the counter and you can get it. So then you also have prescription stuff and things that are, well, wait a second, it's not just information that we can just give out. It starts to be connected and it starts to guide therapy. And those types of applications need a little bit more, they need to be more tightly integrated with the system. And then you've got monitoring type apps, which are like your narcotics, where they're really medical devices, and they better damn well be accurate because patients' lives are dependent on them, and they need to be tightly integrated. So I think you've got this continuum in terms of applications out there. What we're trying to do at TELUS is we think this is a unique opportunity within Canada to when you talk about getting providers and patients, getting a significant number of providers in on our applications or connected to our platform, and a significant number of patients. Then once we have those provider registries and patient registries, the ability to create applications that hang and provide services between the two. And so I think you've got everything from applications that'll be information only, which can be off on the general shelves, to applications that start to guide patients with therapy, which are kind of your over the counter, to applications that are part of the medical record and interact with the medical record, which are your prescription ones, and then to those those ones that are virtually devices. So I think it depends on the application where it fits in that continuum, but I think that's a really powerful way of looking at it. In terms of where what you're trying to do and where to play and who do you need to connect to.
It also speaks to an acute problem we have, which is patients moving across different care settings. So we do pretty well at collecting information when you come into the emergency, or we do pretty well when you come into a physician's office. We can capture that electronically. Sharing that information, exchanging that between care settings. So if you have an awful diagnosis for cancer, you're referred into the cancer system. At that point, they might try to collaborate with a number of care professionals to deliver the service to you. That's not always such a coordinated effort. That involves people working with their respective information systems, and today doing a lot of faxing and phone calls. That's the problem, right? Like whether there is no way the standards aren't there for low cost, seamless integration or exchange of that information in a reliable fashion.
Yeah, the elephant in the room there is that you're not allowed to see your health record. Or, privacy matters, security matters, the intersection of who can see what, when, and how matters a lot. So, two doctors may not be allowed to see your health record depending upon your status and where you are in the system. So how you actually link a free set of data, which is your Fitbit type information where you don't care about it, to your mental health status or your HIV status that anybody can read, is a big issue. And we have some pretty strong laws to protect the individual from a privacy point of view.
Good. Have we got any more questions from the floor there? Sorry, Angela, go ahead. Is there a microphone that we could pass down, Angela?
The question I had is around sort of integrating technology for use within a hospital that doesn't sort of...
The question I had was integrating or bringing technology into the hospital that is designed not to have privacy or personal information and isn't connected to any back-end data systems. Is there a fast and light sort of approval process to get the technology into the health authority, or is it still being reviewed in deep levels when maybe it doesn't need to?
Not any system that doesn't contain personally identifiable information or protected information, depending on who you're talking to, gets to skip some of the steps. But today there is not like some fork in the procurement process early on to say, oh, you're one of those, you get to fast track. You do get to skip, presumably, the dreaded security threat risk, the privacy impact assessment, which is this onerous exercise where we go through and look at the potential implication, what you're collecting, how it's being used, what are the implications and whatnot. But really that focus is around the personal information or personally identifiable information to really understand how this stuff is being used. So if you don't have that, I'm not saying there's an easy path. There's still if you think of medical devices fall into that category, and we go through a huge onerous procurement process just to acquire those devices and whatnot. So,
is there anything changing in there, like to be able to bring in more innovation?
As Paul alluded to, myself and we try to. We do procurements all the time. We're always going out to market, and every time more and more it becomes quite a challenge in terms of looking at what kind of product are we procuring. Is it a service or is it traditional software? That's sort of the model that always has been. We go and find this vendor looks really cool for $1 million and 200 grand a year. They'll sell us, they'll rack and stack the server, and we'll be good to go, and we'll deploy all the clients everywhere. That model's obviously shifting towards a more managed service, but towards hosted solutions. We are challenged. I mean, just about in the past 2 months, we tried to push along the notion of managed services to address some of our needs around particular application options, or what I like to call solutions as opposed to apps. And without luck, the default position was it's just a lot easier to fall back to what we know works. You have to keep in mind as well, and this speaks to the comment about CEOs and an executive level maybe not having a compensation framework that allows them to take that risk. Likewise, at my level, I don't really care. Like at the end of the day, I get my paycheck. Right? Why would I take that risk? Why wouldn't I just toe the line and, here's the templates, here's the forms, go through the process. I'm not incented in any way, monetarily or non-monetarily, to make those kinds of changes. It's one of our frustrations as we're involved in this industry and get quite passionate about it, that we go, this is wrong. We need to change this. No one's sitting there above us saying, change this, aside from Paul occasionally at the board meeting saying, John, this is insane. And I agree, but there's no single individual that is empowered to bring about this change. It's really a systematic, and you have to work within the institutions to bring it about. And we do our best to. Are we trying to change? Yeah, absolutely. Because what's happening isn't working. And if you don't feel the $1 out of every 2 or the 50 cents of every dollar go into healthcare, if you don't feel that today, you will. You will feel it in your schools. You'll feel it in your social, everything outside of healthcare, as we tend to dump more and more money into drugs, doctors, and hospitals.
It's an interesting problem. The first time your software in the hospital can actually be run is when you run live patient traffic through it. Because before that, you can't have live patient traffic to test your software. So how do you do that? How do you write an application in a hospital where you can't actually see information until you go live? But you have to prove it works before you actually go live. We get into a catch-22 situation, right?
Okay, I think we've got time for one more question. I see one at the back here.
I'm someone who's hired on by the health authorities to implement the solutions that are selected. And one of the challenges I encounter consistently across all the projects I've implemented in IT, and I'm a nurse by background, is operationally the business is just not ready. The business is not ready. They haven't thought through what the implications are in implementing the electronic solutions. So I agree innovation is absolutely necessary in order to move forward and to reduce the cost, because there is no other way. We just have to start innovating. But we've got to look at our ground floor, frontline operations and understand and get them to understand that we have to make these changes. And they just have no conception to it. They are attached to paper. They are attached to the ease of solutions that they can come up with themselves without electronic solutions. So I'm wondering, as from a person who implements these solutions, like, how do I convince the directors and the executive directors even that the amount of time that they have to spend with the operations to get them ready to actually implement the solutions in an efficient manner and see the value of what we're actually doing. I'm struggling with that myself. So I'd love to hear the panel's recommendations there.
I think that's I think you hit on something that's a huge problem. And my guidance on this is actually to try to put yourself in the perspective of the practitioner or the people using the tool. And it's hard as an entrepreneur, because you come in, entrepreneurs will come in with a solution, and it's all about the solution. But you don't really understand that problem fully from their perspective, because I've sold software to doctors, And I'm passionate about using the tools for the outcome basis. But the reality is, the way the physicians are compensated, they don't really have the time to run the reports and really get the insights, and they don't. So you can implement technology, and I joke to people where we are with EMR today is like if we sold CRM to all the businesses and everyone implemented their CRM system, but nobody ran reports or dashboards. You get all the worst part, right? Data entry, workflow changes, and you don't run the reports. And that's what I see right now with with what where we are with some of the electronic medical records and applications. It's all the pain. That trough of implementation, they're feeling all the pain. Getting to the other side of that, and when we see our implementations go through, and the first time a physician or clinician has that aha moment of, holy, this thing just changed the way I practice, then they're hooked, right? Because at that point, they're not going to go back to paper. They're not going to go back to their old ways. They didn't like the pain, but that actual clinical benefit. And so, if you're implementing in healthcare, remember, those people are investing their heart rates into healthcare because they really want to make a difference for their patients. So show them how it makes a difference for the patients and link that to what you're doing. And I think that's, a good approach.
My experience has been that IMIT essentially drives practice, and they don't like that. They, ultimately practice should be driving the solutions, and you have to reframe it so that they can see that their practice is driving the solution. But my experience has been over implementations is that we're driving the adoption of the solutions and the creation of the solutions through creating the conversations. And that's key for any of the solutions, whether it be, with a consumer or with an organization like a health authority or a program like home health, for example.
We see that often and often accused of such of IT driving the agenda. I think looking at where we are in the industry and sort of where we've come from, the era of when electronic health record or EHR was all the craze, it was really IT, people converging around IT to focus on this particular thing called the computer and the electronic health record, and how we would deploy these workstations with these clients, and they would communicate, and we'd do things like order labs and order tests and that. And that was really neat. But then the internet came along, and technology and the microprocessor itself is now ubiquitous. It's everywhere. We all carry one, maybe two, three. I don't know. Some of us wear them. They're everywhere. And the healthcare organizations, very much so here in Canada, haven't really adjusted to that dynamic. We're still sitting there sort of pushing the IT envelope. Lately it's around analytics. Before it was around EMRs, but coming from IT. If you look at my role, enterprise architect, well, I don't like the name architect, but let's just go with it, enterprise architect. I report to a CIO that's running an IMIT department. Really, if you're familiar with sort of enterprise architecture approach, things like TOGAF and whatnot, suggests that you're actually working with the whole organization, that you're working with strategies coming out of sort of at the executive ranks or through those senior leadership, the senior leaders, not just IT, but collectively saying what problems are we solving. Today, just about every problem we go to solve involves a microprocessor or it doesn't. It always seems to involve IT in some way, whereas in the past it was more of a siloed activity. So it's only, I think, through the evolution we'll be forced to, I think, one, put IT as a very secondary service, more of and elevate sort of the health informatics piece or the information management piece to be aligned more with the business, so that we're working alongside people getting the reports they need to inform their decisions instead of just going off of ad hoc or decisions from the gut. And as well, we can have solutions that actually meet the business needs and it's no longer like an IT project. In fact, we'd like to just put IT on a business. Hopefully that will happen one day, because healthcare really shouldn't be investing in IT per se, and as a pure play. It should be investing in solutions, of which IT today is part of just about every solution we play with.
Great, thank you. I see the music has started. I'd like to have a big round of applause for our panel. Excellent discussion tonight. I'm going to turn it back over to Tim just for some closing comments.
Thank you. I'd like to thank the panel a lot for sharing a lot of interesting stuff. Also, I know that we're running a little bit over time, and I'm standing between you and beer, so I'm just going to make this into very quick point form. Corporate membership, really good. See Chris. Membership, really good. See Chris. Corporate sponsorship, absolutely fantastic. Worthwhile. See me or Chris. Have a beer over here. Panel can continue this discussion over beer, and there's lots of interesting things that we can do. I'd really like to thank everybody for coming out, enjoying the show, and please come back next month. We got something very interesting. It is what is inspiring women entrepreneurs in our city. Joining us will be Dr. Alexandra Greenhill from My Best Helper, also a medical doctor who turned entrepreneur, so a nice connection there. Kate Belenke, COO of Plenty of Fish. T. Nicola, CEO and co-founder of Wealth Bar, surprise special guest if she can make it, and we can get her into the schedule. We will have somebody very interesting for you to listen to, but I'm not going to tell you until she shows up because it will be worth the surprise. And with that, thank you all for joining us.